Mr. Lim. I'm a consultant gynecologist. My NHS practice is at Eastern North Hertfordshire, which is Lister Hospital and Stevenage. So at Hertfordshire, really. I thought I'll just spend the next half an hour or so talking about who I am. I'll briefly discuss endometriosis, symptoms, and I suppose the question is how you navigate through the health system. And as we are in the UK and majority of the audience are eligible for NHS care, I'll be talking only on the NHS care. And I expect there will be quite a fair few questions, which I will try and get through. So who am I? I'm a gynecologist, but I first came to the UK to study medicine, and I was at Southampton. And after that, I went into obstetrics and gynecology training in Scotland, in Aberdeen and Inverness, actually. And then I did my specialist training at the north of England. So that was mainly in the centres of Newcastle and Middlesbrough. 2018, I became a consultant gynecologist at Hertfordshire. And I suppose the idea of getting me here is really to improve keyhole surgery and endometriosis care. I am also an active member of the BSG, which is a society of gynecological endoscopists. And within this society, I participate very actively in the training subcommittee. So we organize courses for the other gynecologists around the country. So endometriosis is, we understand it enough to know what to do about them, but not enough to know what to do about them, if you see what I mean. We know it's painful, but we don't really know why it happens. We know it's common, but we don't really have a good grasp of how common it is. It is painful during periods. Some women have pain after sex for weeks, so they can't have sex. Sometimes it's painful in your bowels, especially on the time of period. Sometimes it is painful when the bladder is filling or the bladder is emptying. And very often endometriosis is accompanied with heavy periods, not just painful, but also heavy. If it affects the small bowel, then women also describe bloating, and bloating is not always cyclical. It doesn't always follow the cycles. And so women sometimes tell me like they feel like they're 8 months pregnant, and they can even show me pictures of how big the abdomen becomes, but they're not pregnant. And pain is tiring, so sometimes women can't lead a normal life because it's so exhausting. And then we're interested about staging, what stage of endometriosis we are. Staging doesn't really mean very much, to be honest with you. It's not very helpful. I think this American Fertility Society, this is most commonly used staging for endometriosis, first described in 1976, updated in 1985. I think back then, a lot of the endometriosis surgeons are cancer surgeons, and they're probably also more interested in fertility. So really, they think of things as stages. Stage 1 will become 2, 2 will become 3, 3 will become 4. But endometriosis, I'm not sure really behaves that way. And also by staging, it also means that if you have stage 1, sooner or later you become stage 4. That's what happens with cancer, perhaps, but I'm not sure it happens with endometriosis. We don't have enough scientific proof for that. So when somebody says they have stage 4 or they have stage 1, it is less helpful. And you can see how complex it is with staging. It all goes by where the disease is, and depending on where the disease is, you get points. Some disease scores 16 points, some disease scores 20 points, some scores 1 point. And then if you have a total of more than 40 points, that's stage 4. And to be honest with you, even consultant gynecologists, most of us can stage 1 or nothing, or we can say stage 4, but I'm not sure all of us know how to tell the difference between stage 2 and 3 or 1 and 2. So I would suggest that staging doesn't help. It's more important to describe where it is. So a bunch of gynecologists met up in a hotel. It was actually the Enzian Hotel. That's why it's called Enzian. About a decade ago. And they came up with the Enzian classification. And with Enzian classification, they then split it down to where the disease actually is. Is it at the peritoneum, at the ovary, at the tubes, and even within the pelvis? Is it at compartment A, B, and C? It's useful to describe where the disease is, but it doesn't tell us how badly it affects a woman, in terms of their pain, in terms of their fertility. So we don't really have an ideal staging yet. So I think what is more helpful is a description by your surgeon as to where the disease was and what was done about them, and also how endometriosis is affecting the person. So we'd consider what the woman's priorities are. And we know that surgery will improve the symptoms. Surgery will improve the pain. This is well researched and published. Like I say, I'm going to talk about NHS. I think in private sector it's completely different, and people will, contact a private hospital and have their care that way. Some of these pictures that I share are pictures that I took from a national congress, the BSGE scientific meeting a few years ago. At that time, it was hosted at Wales, and we had representation from a charity called Fair Treatment for Women in Wales, and they shared a few pictures of the difficulties women go through. These are drawn by women who have endometriosis, and I thought they are very useful pictures, so I took them. So courtesy to them, really. But I suppose, what do you do when you have endometriosis? I think it's reasonable to discuss your symptoms with your GP, especially if you're not sure if it's endometriosis or not. To a certain extent, it is acceptable to have pain and heavy periods, but it really shouldn't be so bad that it affects your quality of life. It really shouldn't be so bad that you can't go to work, can't go to school, can't go out with your family. So I think we should distinguish ourselves what normal and abnormal is. And if you feel it is abnormal, then it's entirely reasonable to discuss with your GP. And I think it is reasonable to give them a chance to sort it out. And I mean a chance probably about 6 months. So this is my suggested pathway. I think when we come to discussing pathway, it's almost like this is a rule, and if you don't follow it, you are breaking the rules. I personally don't feel we should do that, because every woman is different and we do different things in life at different times of year. So the managers, the CCG, these are the people who pay for the NHS, they like pathway because they like to know what do we do, step 1, step 2, step 3. But I think it's more important to individualize the care. And that's why I think many of you would experience that the best endometriosis service you come across will be those that are very individualized to the women themselves. So give them a chance to sort it out. I think 6 months is reasonable. If you're going to go on a pill, if you're going to go on a coil or an injection or an implant, if you're going to try painkillers, 6 months is reasonable to sort it out. But if after 6 months of trying with primary care, or if there's a background of having done all this before, then it's reasonable to request from your GP a referral to gynecology. And depending on where you live, depending on what the GP is aware of that is available in your area, there is a difference between general gynecology and a specialist endometriosis clinic. Most likely you'll be referred to general gynecology, because the majority of gynecologists, we do have experience and expertise in the management of hormonal contraceptives and the management of endometriosis related pain. So most gynecologists will spend at least 7 to 8 years in training. This is after their junior doctor's year. They spend another 7, 8 years of training in obs and gynae before they actually become consultants. And the referral, you will, even if you see a registrar, you will actually, your input will, there will be input in your care by a consultant, or in all cases will be discussed with a consultant. So, and if you're not particularly confident or happy with the suggestion, then it is your right to request a second opinion. It may be annoying to request a third, fourth, fifth opinion, but also it may also tell you that actually maybe if two gynecologists says it this way, that's probably the right thing to do. But when it comes to second opinion, some will worry that actually, well, you're just going to ask your friend who will say the same thing. So sometimes it's better to just go back to your GP and say, can you choose somebody else? Or is it okay if you refer me to this other hospital, which is a little bit further away? And I think most GP will be willing to oblige. Specialist endometriosis clinic didn't used to be everywhere, but I think now most hospitals will have a degree of endometriosis clinic. And they're generally reserved for the very complex surgical cases. Surgical, but not necessarily medical cases. So sometimes you have very cases that are a bit complex and challenging to manage, but surgically may not be complex. And this is how I feel anyway. I think a woman is an individual, and just because surgery is easy doesn't mean that the case is straightforward. So, but most specialist endometriosis clinic in the country focuses on the complexity of the surgery because there are not many surgeons with that level of expertise. This is a nice guidance that was published in 2017, and it really stimulates most health services since then to streamline it so that a specialist endometriosis clinic is available to every woman in the UK. So if your local NHS hospital follows this, which they will do, then there will be a pathway to get you into specialist service. The British Society of Gynaecological is the society I was talking about earlier on, a society of gynecological surgeons, and endometriosis is frequently very high up in the agenda in that society. They are the ones that grants approval and endometriosis center status. So I run one at Hertfordshire. There's about 50 in the country now, and it really just means that there is a dedicated team of not just gynecologists but also nurses, colorectal surgeons, urologists, pain specialists to manage these complex cases, and we will feed in information anonymously into a national data so that there's standard setting, so that we're sure that what is done from these endometriosis centers are up to standard. And in fact, we have to submit videos to assess our peers to make sure that what we're doing is still the right thing. And this is a regular thing. So that's really what endometriosis center is. But of course, there are local support groups. Endometriosis UK is a very reliable source of information. So I would say allow the system to filter you through, and if it does appear that you will need to be managed in an endometriosis center, then absolutely fine. I don't think any of us would restrict that. Of particular interest is the surgical activity within the NHS. Endometriosis has been in the news because it seems to be our patients that are asked to wait, because when everything stopped due to COVID, only cancer happened. So late March 2020, only cancer, only the emergency operations can be done. April to July, only the cancer, the life-threatening things can be done. I suppose partly is down to the fact that we don't have enough anesthetists. Anesthetic doctors are also the ones that really support the patients who are very ill with COVID. And most hospitals expanded our ITU capacity. And to give you a bit of an insight, the anesthetic machines were being used as ventilators to begin with, when we were still waiting for the ventilators to come. So it was pretty dire last year. But then comes August, we were starting to go back to activities. And I think thanks to the British Society Gynaecology and ongoing discussions with NICE, which is the National Institute of Clinical Excellence, we have agreed that for women with severe pelvic pain with endometriosis, they should be categorized as priority 3, which really means, if you believe it on paper, it means we should be obliged to try and conduct the surgery within 3 months. This is when we had great plans to resume surgical activity. August to December, there was resumption of activity. Every specialty has their own priority patients to get through. So actually, we try and get many patients through. But I remember this December, near the end of December, I was operating, and it was halfway through the day when I have been told that from now on you must stop operating. Your next case must be cancelled. They didn't really tell me why. I just had to respect senior management decision. But I later discovered that that was the beginning of second wave, and we really had to stop everything throughout January and February and most of March. Second wave meant we had to stop a lot of non-cancer operation again. So what I mean by the last line here, huge variation in surgical activities nationwide, is that when I have this conversation with my other friends, my other colleagues who does endometriosis surgery, I discovered that even within the same region, different hospitals are doing different things. Even within, for example, even within London, parts of London will be doing absolutely nothing, and parts of London will be doing other things, moving on to the non-cancer work. So it's really very varied because the decision is made based on what is faced by the individual NHS trust. My teacher at Middlesbrough, I have heard, they have paused a lot, probably a bit more than me, and it really varies in terms of what everybody was doing. But things are back up and running now in most places, and I trust you will respect that there is a huge backlog of cases. It's not all doom and gloom. I think there has been progress despite the pandemic. Many of you will be aware of the APPG inquiry, the All-Party Parliamentary Group inquiry for endometriosis, and it's a long, it's not that long a document, but there is a bit of a read into it. And a few things I picked up is that yes, they're trying to reduce diagnosis time to 4 years because conventionally we know that in the UK it takes us up to 8 years, not always 8 years. So they're saying 4 years. I think if we go by the strategy I suggested, which is for many of the women around my area, then realistically 6 months of trying, if that doesn't work, refer, even if there's a 3-4 months wait, by the time you see a gynecologist, it'd be maybe about 1 year from your symptoms. And if there's a 6 months, 1 year wait, we should then get to a laparoscopy point comfortably within the 4 year, hopefully within the 2 year mark, to come to a diagnosis. So that's my ambition anyway. I know that's not always the case. The APPG document also says that there needs to be a nationwide adoption to that guideline, the NICE guideline. And there already is, I think, but maybe there are pockets of the country that are still catching up. So I think that is movement towards a better care. There is also a commitment to research because it goes back to what I was saying before. We know enough, but we don't really know enough. So we can do what we can with what we know, but it would be helpful to have more research in a subject like this so that we can, have better options, better treatment options, or a better idea of how we manage this very complex disease. Robotic surgery is gradually coming in. This is a picture I share of a robotic surgical system, and I use this surgical system. And I think increasingly a few endometriosis centers are coming to use it. It is better technology. The operation is still done by the surgeon. It's just I would control the robot, but we would see better, and I like to believe that I can then cut more out. There's less pain. But I think even without robotic surgery, gynecology is actually a field of medicine that has embraced minimal access approach from very early on. Gynecologists are the first doctors in the world who did laparoscopy. Back then, and we were able to do sterilization that was earth-shaking, and it still moves on. And I think most surgical specialty now have moved into doing laparoscopy. But I think technology does mean that we will hopefully improve what we are able to do surgically, and we'll have improved patient outcome. So there is progress despite the pandemic, despite the delays. There is progress. Next, I'll talk about what will happen during an appointment. I think you're likely to see a consultant, but you could also be reviewed by a nurse specialist. And the nurse specialist will either be somebody who is new, in which case we'll discuss every detail with a consultant, so you will get good care, or somebody who is very experienced in endometriosis will know what are the important things to discuss. If you see a registrar, and the registrar tends to be somebody in training, but has already done their exams. So they are, with endometriosis, we all know, even within the hospital, we all know that it's more complex, and we tend to have the more senior of the registrar who would sit in clinic, so that they tend to discuss most cases with the consultants. So all I would reassure you is that the consultant will very likely have a direct input into the plan during or after the appointment. So consultant's not around, I'm afraid we need to discuss consultant, they will get back to you. And most services cannot afford more than 20 minutes into a single appointment. So be prepared that you may need to be invited in for more appointments, because it's important we give you the time to go through it. And GP appointments, they're like 10-15 minutes. It's not their fault, they have so many patients to get through. So I think time with the patient outside of the operating theater is equally important. So be prepared for more than one appointment. And if you are discharged, then you can request your GP to make a new referral when the problem comes back, because we really have no idea whether it will be back in 6 months or 6 years. But what is within your control is you can then speak to your GP and say, I've previously seen this person, can you please mention this person's name in the referral? And most surveys will then try and match you in back to that person. So a named referral if the problem comes back. Particularly to pathways, like I said before, it is useful from the managerial perspective in planning the healthcare, but not always designed to be in the patient's best interest. Everybody's different. Some women would tell me, oh, I'm due to go for IVF soon, so I would like my surgery after my babies, or I'm due to IVF soon, I need the surgery before the IVF. Scans, ultrasound scan can be offered by GP at the GP stage, but MRI scan, I would suggest you don't let your GP request it, simply because MRI is a very sophisticated machine and there are many settings. If we get the right pictures, 350 pictures is enough. If we don't, I've seen some MRI come through and there are 4,000 pictures in it. So it kind of depends on what question is being asked. It's really only useful for us in planning the surgery rather than looking for endometriosis, because the best way to look for endometriosis actually is a laparoscopy. So I think we'd reserve that to the gynecologist to decide if an MRI is useful, and when they decide that, they will then specify in the request what exactly they're looking for. So the radiologist and the radiographers will know what setting to put on the MRI to get the most appropriate scans. There's really only 4 things that can be done with endometriosis. This is the way I see it, the way I've been taught to see it. You could choose to do nothing because it is benign. This is not cancer. You could choose hormones. So any of those kind of hormonal contraceptives. It does mean that you can't conceive, but if there is a suitable hormone for you, it is entirely reasonable to remain on hormone right through to the menopause. Now, hormones, I think it really varies. So there is a degree of trying to work out, is it the coil, the pill, the injection, the implant, which one works best. And so hormones and doing nothing, they probably won't make the endometriosis disappear. But coming back to the point of it being benign, as long as you have a reasonable quality of life, you do not have to have surgery. But when it comes to surgery, there are two types of surgery. There's conservative surgery, where I would go in and cut out the disease or treat the disease. In some cases, consultants will burn the disease rather than cutting it out, which is thought to be equally effective, but it does vary case by case. Or hysterectomy. Hysterectomy, I suppose, because quite often endometriosis, people with endometriosis also have adenomyosis, and that's when you have endometriosis within the muscle wall of the uterus. And so if there was adenomyosis, then conservative surgery after conservative surgery, cutting out disease after disease does not necessarily help things. It will be that getting rid of the uterus, meaning no period, that helps. But we all know, and those who don't will be wrong, we all know to expect that patients will come back. So the symptoms can come back, you would come back. So that is when you would discuss a named referral with your GP. So my management pathway tends to be that I individualize the care depending on the treatment options that have been previously tried or that we are looking to try that is acceptable to the patient. And if it does come to a point of discharge, that I would then mention to the GP to feel free to make a new name referral back to myself. And I expect many of my colleagues will manage like that. Feedbacks is useful, both good and bad. If you want to give feedback, you can write to the doctor or to the department. You could write to the hospital. If there's lack of service, you could even write to the MP so the MP can put pressure on the hospital. And it's certainly letters from you to the MP that led to the APPG discussions and publication. So that's that. But of course, we're also moving into social medias. You can go on to websites to leave feedback, Google reviews. And with these reviews, we can't do anything about it. So if you write things that destroy us, they are pretty, they are actually very transparent. Be kind, but I suppose feedback is useful. It's helpful for fellow sufferers of endometriosis to know, if any particular doctor is good, any particular doctor is helpful, that kind of things. So I will stop there, and I know there's a few questions to get through. So let's just see if I'll stop the share and I'll give it back to you, Rebecca.
Yes, we had some questions submitted beforehand, and we've also had some questions submitted during the webinar. So I'll start with some of the pre-submitted questions. There was a few questions about sort of the impact, also on the live questions about the impact of hysterectomy, like what should you do if you're worried about how your body will react to it, and the implications of taking HRT.
So I think hysterectomy, when it comes down to hysterectomy, your consultant will discuss with you in detail what exactly is going to be done. A woman's body has the ovaries, the fallopian tubes, the uterus, and the cervix, and then there's a vagina. So a hysterectomy, in its strictest sense, means the removal of the uterus. It does not necessarily mean removing the ovaries or the tubes. So if it was a hysterectomy for endometriosis, if you think about it, the more important operation to do is to cut out the endometriosis. If there was adenomyosis, then hysterectomy with cutting out the endometriosis is what helps. When you do a hysterectomy, it would be reasonable to remove the tubes, because the tubes are really only useful for fertility. If somebody's having a hysterectomy, then really you don't need the tubes. And we know that there are some serious forms of cancers that actually arises from the tube rather than the ovary. And so it's a good chance to remove the fallopian tubes. And I think the key thing is also to remove the endometriosis around it. The hormones actually comes from the ovaries. So if you remove the uterus without removing the ovaries, then a woman does not go through the menopause. A woman just has no periods and cannot get pregnant. That's kind of all that means. If the cervix is removed, which is one part of the uterus, then as long as the woman has been up to date with the smears and they've always been okay, then that also means no smears, no further smears required. So I think having a hysterectomy does not necessarily mean you need HRT, because if your ovary, if you have at least one ovary remaining, you do not need HRT.
Okay.
So that would be the thing to clarify. But if it does mean that you remove your ovaries, then HRT is fine, provided your consultant knows what choice of HRT to go on. And most of us, what we will do is we will give you a combined form of HRT without the cycle, so that endometriosis wouldn't come back.
Okay.
So
Yeah, there were some other questions related to hysterectomy in terms of if you have post-hysterectomy sort of complications, pain and fatigue, things like that. Are there then other options? You know, what can be done about that? So there's a lot of concerns here about whether it's worth it to have a hysterectomy. Does the damage outweigh the benefits? That kind of thing.
I think it would depend case by case. But to be honest with you, what we find is that most women who have a hysterectomy loves it. You don't have many people who regrets it. But of course, it's all down to your discussion before the surgery. Most women will find big improvement, because even if you have pain, if there's no bleeding, many women are quite happy. But I suppose your concern is, could it come back? And so I think if there was endometriosis, then it would be important to specify and stress that the hysterectomy needs to be done as well as the removal of endometriosis, not just purely a hysterectomy. And if that was the case, then the likelihood of endometriosis coming back is rare. But managing complex endometriosis, I think in the endometriosis clinic, we will see the odd patients who come through who's already had a hysterectomy but still has pain. And if that's the case, then we will manage that. That is, I must say, that is a minority, but it does happen. Don't assume that it will be you, because most of the time you'll be fine.
Okay. Some question here on hormone treatment. What is your opinion on hormones to stop ovulation? Although not a cure, will this potentially help reduce pain, and would a partial hysterectomy, just removing ovaries, stop this pain?
So two questions there, isn't it? So hormones to stop ovulation is a good idea if you are not intending to conceive, because it does mean that your periods are lighter and endometriosis pain is better. But it doesn't always work. That's the only downside. So if you find one that works, for example, if you have a coil that stops ovulation and it works, great, swap it over every 5 years. If you have a pill and it works, then that's absolutely fine as well.
Okay.
So that's how I feel about hormones to stop ovulation.
Okay. And there's a sort of specific question here from a live question related to that, which is the progesterone only pill recommended in addition to a coil like Mirena? Because this is someone who can't take the combined oral contraceptive pill.
Yeah.
So would it be recommended together?
I sometimes do that, I must be honest. When it comes to managing the complexity of a condition such as endometriosis, we really need to try and get a woman to a reasonable quality of life. and if we've tried a few things, I do sometimes suggest going on a progesterone pill in addition to Mirena. In fact, there's no harm in going on a combined pill in addition to Mirena as well. Mirena is a very reasonable treatment, but it has a very, very small amount of progesterone. And
Okay.
for some women, that's just not enough progesterone to suppress the disease for pain control. So I do that, yes.
Okay, and there's a couple of questions about endometriosis and sciatica, sort of comorbidity or related pain.
Mm-hmm.
And are there any sort of, what is your view on that? And are there any sort of care pathways to manage someone who has both of those?
I think it kind of depends on if the sciatica is endometriosis. I think if you have cyclical symptoms, as in this sciatica is always worse during a period, then yes, perhaps there is endometriosis that is affecting close to the sciatic nerve, which is a nerve that runs through the back of the buttock, and that can then cause kind of leg pain behind the leg. I think this is a condition that needs to be assessed and discussed with an endometriosis specialist. It could also be really that they are two completely separate conditions, that you do have endometriosis and you have sciatica, and they are separate. So you want to manage both separately.
Okay.
And I suppose pathway-wise, there are a few surgeons in Europe who has found endometriosis that is actually sitting very close to the sciatic nerve, in which case they actually surgically dissect the sciatic nerve and then remove the endometriosis from the surface of it. It is not a common operation, but there are a few people in Europe who does it, and certainly one or two in the UK who does them. So if it does come to it, then consultant will be able to point you in the right direction.
Okay. Another question, also sort of linked to hormone treatment. As some with endometriosis can't tolerate hormonal treatments, what alternatives are becoming available, especially where pain is not the main problem and surgery isn't an option?
Mm-hmm. So I would speak to the person and ask exactly what is the problem, because if pain is not the problem, then the only other important problem is fertility. So if pain is not really a problem, you don't have to be on hormone.
Okay.
But if you're unable to conceive, then you don't really want to go on hormones as well. So then we would be looking at things like start trying or refer for IVF or investigate to see if there's any reason to get on with the process of trying to conceive.
Okay. Find some of the other questions.
Some of the questions are mixed and I forget basically. So if there's anything I missed.
Yeah.
Yeah.
In your opinion, what's the best treatment for endometriosis when it's only physiologically present, and to a lesser extent, but the pain is extreme and debilitating? So perhaps in that, I think that this is one of the questions that came in before.
Yeah, I think that stresses the point that endometriosis, it doesn't have to be stage 4 to be debilitating. And so I will individualize the case. And also when I run courses, I've also delivered talks and spoken to other consultants who shared talks with colleagues to show that sometimes we think it is minimal and very little disease, but actually when you look properly, there's a lump, there's a nodule somewhere. So it may be a matter of getting a second opinion and looking again, and individualize the case, I think.
Okay. Another question here about pain relief. What kind of pain relief is recommended for severe pelvic pain when fentanyl and diclofenac suppositories don't work?
Do you know what? As from a gynecologist perspective, I think if these sort of things don't work, then we should be really thinking about offering surgery. because surgery probably will work. But there are the odd cases when they don't really work as well, then we would get the help from a pain specialist. So, and sometimes pain specialists will try an alternative form of pain medication, something like gabapentin and pregabalin. But these, if we start these need to be supervised by a pain specialist, because there just isn't the evidence out there, the research evidence out there to say this is useful for pelvic pain. So it's not going to be licensed for that use. But there are some women who are on it and carry out a good quality of life. Yeah.
Okay. Fine. In your experience, can endometriosis worsen after having a baby, for example, pelvic pain?
I think having a baby is a bit irrelevant in the progression of endometriosis, apart from the fact that there is that year where you have no period and things are fine because you have no periods. But I think many women I see have been told by their doctors that try and have a baby and after pregnancy it will all resolve. I don't think it does. I think if you had a vaginal delivery, maybe the neck of the womb is a bit more open, so many women find that the periods are heavier after having a child or two because the uterus becomes bigger and the blood can come out easier. So sometimes I suppose it can get a bit better. But scientifically, having a baby doesn't remove the disease. So having had a baby, it's only that time of respite that you had. But when the periods come back, I expect that the symptoms will also eventually come back. But priorities changes, for women once they've had a baby. So it may be that it becomes less of a problem because there are bigger problems. But I don't think they will worsen or get better. I think if that is the case, it will still be like that.
Okay, and there were a couple of questions about sort of diet and lifestyle, particularly in relation to some women who have bloating. Are there any sort of diet or lifestyle approaches that can help?
Yeah, I mean that's a good question, and Endometriosis UK, the website does have some suggestion around it. I think it's very much down to the individual to experiment what works. Scientifically, we haven't got enough to say there's any particular diet that is better than the other, but I suppose we have seen that avoiding gluten sometimes help. Lifestyle is down to adjusting your lifestyle. So if endometriosis pain is really bad, but it's only bad 1 week, then it may be that if you're able to, then you adjust your lifestyle. You just do less during that week, for example. So I think lifestyle is very individualized. Everybody is different, and it's up to the individual to experiment what works. And we certainly will not tell you shouldn't do something or you should do something. I think we would, but we should be there to support you and help you with what you are trying to do and achieve.
Okay. Yeah, I'd just add from an Endometriosis UK perspective, one thing that we highlight is, as Dr. Lim mentioned, there's a lack of evidence around diet and lifestyle approaches. So while we have some information on our website, we can't really say very much because the evidence is just not there.
Excellent. So any more questions you think I could cover?
Yes, there are. There's a lot coming through and I'm trying to manage the old ones with the new ones.
You could do with another moderator, can't you?
Yeah, I could actually, yeah. Okay. How long should you expect to be pain-free post-Prostap therapy, and can surgery help with bowel and bladder symptoms?
Okay. Prostap, and unfortunate to say that many of gynecologist colleagues also believe that, but I don't think Prostap is a treatment. I think it is more a respite, something to buy us time. For example, if you're waiting for surgery or you're waiting to see somebody. But there are occasions when I would use ProStep or the equivalent to manage in the long term. And if that was the case, it would be off license. It would be after thorough discussion with patients. For those of you who don't know, ProStep is a medication. Is called leuprorelin, sometimes known as Lupron. It is equivalent to triptorelin or decapeptyl, and it is also equivalent to Zoladex or goserelin. So these are injections that will shut down the ovaries. And you get this injection once every month. Because it shuts down the ovary, the woman goes into a temporary menopause. But if you don't get it the next month, it's every 4 weeks actually, if you don't get it the next month, then your ovaries, the ovarian cycle comes back. So I think if you are having the treatment, if you're having the ProStep, in the process of having it, yes, I expect things to get better, probably after a few weeks, but definitely after a few months, you will notice an improvement. It might take a few months for your periods to eventually stop, for the pain to get better. But I suppose if endometriosis is very, very severe, then sometimes even with these injections, the pain doesn't go away and you need an operation. So I wouldn't consider it really a treatment, but rather some more of a respite. And if it is being used, there should really be a plan as to what should happen next. But if you're asking for how quickly it works, probably within a few weeks is my experience.
Will another treatment about pain management, will mid-cycle pain benefit from medical management? And this is someone who says their symptoms have got worse 1 year postpartum.
Yes, I think so. I think as long as it follows a cycle, then it is reasonable to try medical management. Medical management meaning either painkillers or hormonal contraceptives to prevent ovulation. If it is really mid-cycle and if this person has very regular cycles and they know it's exactly in the middle of the cycle, then what you're experiencing is probably pain from the process of ovulation. Ovulation is when the ovary releases an egg. It actually creates a pop in the ovary. Some women can feel it. Some women find it painful and will need ibuprofen, during that time of month. I think if it is really mid-cycle, you don't have to go on a hormone because actually you know when it's going to come. You can start taking it, you can try and manage it that way. Or if you're not particularly trying to conceive, then having hormonal contraceptive, even the cyclical one, even if you have a combined pill that you take for 3 weeks and stop for a week, that works by inhibiting ovulation, and that will also improve mid-cycle pain. So scrolling through the questions now, because we've lost Rebecca. It would be interesting to hear Dr. Lim's view on how we advocate ourselves as endo patients. Prior to diagnosis, it can be challenging for us to have our voice and our symptoms recognized. It takes many women longer than 8 years to receive diagnosis. Question from Jane. I think working with charity is helpful, because working with charity, you will then have more collective voices. But I have discussed in my slides, it is within your right to request a second opinion. And hopefully that way you would then get an alternative individualized care. Next question I can see in the chat room is about dietary lifestyle, which I've answered. Another question about progesterone pill in addition to the coil, which I've answered. If you still ovulate, would you still grow endometriosis cells? A question by Joanna. I think the answer is probably, but this is where we come to the point where we say we don't really know how endometriosis works, because there was a theory called the Sampson's theory, where we thought maybe the endometriosis cells had moved from the uterus, spilled out through the tubes, and that's why you get endometriosis outside of the uterus. But that's not true, because people who had sterilization and the tubes clipped still get endometriosis after the sterilization. So I don't think that's completely true. Then there's also some that believe maybe it comes from embryology, from when you were still a baby, because where endometriosis likes to be is the ovary moves from where the kidneys are, and it moves down into the pelvis actually when you were still a baby, and that's where endometriosis likes to sit. It likes to sit along the path between the kidney to the pelvis. Could that be an embryological origin? I don't know, but if there is, then you shouldn't then have new endometriosis after you cut them out. So, but people do come back. So is it because we missed it the last time, or is it because something new has formed? So not entirely sure about that. I see there are some kind words about me. Thank you very much. I wanted to ask if you've heard of other people experiencing panic attacks with acute 10 out of 10 type pain with pins and needles in the hands and legs, feeling as though you're about to pass out. Is this normal? Question by Joe. I think this shows how much pain you're in, actually. And if you're in this much pain, then I don't think it is normal. Of course, pain is subjective. Everybody handles pain differently. But I think if you have this kind of pain, pins and needles, then it must be very bad pain. So I don't think it's normal. I think it's reasonable to seek help. What causes the ovaries to sit close to the womb? A question by Marie. I think that is because if you have endometriosis on the surface of the ovary, then ovary naturally sits close to the womb, sits behind the womb. Then after times of when you bleed from endometriosis, you can get scarring. Then over time, it does then get stuck and sit close to the womb. So endometriosis is the answer, is what causes the ovaries to sit close to the womb. I see you're back, Rebecca. Was there anything you wanted to add? Or
yeah, I got chucked out, unceremoniously chucked out.
Not by me.
Yes, there were. No, it wasn't you. No. I think it was my internet connection, which is, I'm in the room in the house where it's very good, but I think it just kind of faltered for a moment, and then it took me several minutes to get back in. So yeah, there were some more questions that came through. I don't know if you've answered this one. What is hematosalpinx and the risks it poses, and what is the treatment plan when caused from endometriosis?
Hematosalpinx means blood inside the fallopian tube. It very commonly happens during endometriosis when it's very severe and is affecting the ovary, because at one end of the tube, the fallopian tube is a tube, at one end is the uterus, at the other end is attached to the ovary. It's not all completely sealed up and attached to the ovary, it's just kind of partly attached with bits hanging off. So hematosalpinx is when actually the endometriosis is so bad, it blocks up completely that end of the tube, and then the tube becomes swollen. But because there's endometriosis there, inside this tube, rather than having fluid, is actually blood. And we know that usually from MRI scan or during a laparoscopy, we see a swollen tube. And when we treat the endometriosis, we cut open the endometriosis, then we can see that what comes out is all blood. So that's why hematosalpinx is. I think it is relevant for women who are keen to conceive, because it is not very good for implantation. So if you're going to go for IVF, for example, they tend to say, remove that tube before we do embryo transfer, because the belief is that the fluid that's inside that tube, if it can't come out this way through the ovary, it will only go out that way into the womb, which is not going to be good for a developing embryo. So that's what hematosalpinx is. Okay. Anything else you've picked up?
Yeah, there's a question on the live stream. Where would you expect surgically to find endometriosis affecting the bladder and bowel?
Where will I, or when will I? Sorry, I didn't quite.
Where would you expect surgically to find it?
Okay, so two ways to look for the bowel bladder endometriosis. One is laparoscopy, because it's going to be outside of the bladder, and the other way is a cystoscopy, where you put a camera into the bladder. I must say it's not common to have endometriosis in the bladder, but it is common to have cyclical bladder symptoms. So going to have, they will feel that it's painful for the bladder to fill and empty. Because I suppose schematically, if you look at a diagram, they look like they're far apart, but in reality, the bladder sits right next to the womb, right next to the bowel. So if there was endometriosis near there, you would have those symptoms. But more common is endometriosis on the outside of the bladder, which can easily be excised. Less commonly is that the endometriosis is inside the bladder, so which can only be seen by a camera into the bladder. So I sometimes do that during an operation. I'll also look into the bladder for that.
Okay. There is a question here about pathways for thoracic endometriosis, which unfortunately I know they don't really exist at the moment. So someone is waiting for a referral, and they said, will a routine gynecologist be able to investigate thoracic endometriosis?
I think if we're looking for thoracic endometriosis, I think it's probably best asking the question to an endometriosis specialist first, ideally an endometriosis center. Pathways don't exist because it's rare. But is it really rare, or is it just that we don't recognize? I suppose that's the other question. But pathways do exist for people with endometriosis at unusual location. And I suppose increasingly we are accepting that bowel disease and bladder disease is not unusual. But if somebody really has very classic symptoms of chest symptoms that follows the cycle, then I think your gynecologist will be able to pick that up and will be able to point you in the right direction. We all manage things a bit differently. When I do a laparoscopy, I always look up to the underside of the diaphragm to see if there's any endometriosis there, because I suppose the end of the thorax is the diaphragm at the bottom, and it could be on either side of the diaphragm. It's on the lower side of the diaphragm. It could be on the other side of the diaphragm where the lung is. It could be on either side of the lung. It could be the inside or the outside of the lungs. And one of the difficulties is scans. MRI can't really see thoracic endometriosis. CT can't really see thoracic endometriosis. And if you get a cardiothoracic surgeons to put in a camera into the lungs, they won't necessarily know how to recognize what endometriosis looks like, but they'll be able to recognize what is normal and what is not normal. And what is not normal, they would tend to remove it. And so I think for the many women who had chest symptoms, who had that procedure done by a cardiothoracic surgeon, even if they did not have endometriosis, we don't get many that comes out to say that, oh, it turns out to be endometriosis. But there have been some, and it's been described. There is also a lining outside of the lung, inside of the muscle, called the pleura. And sometimes there's endometriosis there, and these women will have punctured lung and pain when they breathe, only during the time of period. And so, it is rare for this kind of for thoracic endometriosis to happen, but when it happens, it tends to be quite obvious. So your doctors will be able to identify that and refer you on. And then I think we will have to individualize the care, because there's not that many, and it really varies what the priorities are at that time.
Okay. Right. Well, we've come to the end now. Thank you so much for your time tonight, Dr. Lim. I'm really sorry we haven't been able to get to all the questions, but hopefully you've answered ones that address most people's concerns. I've had the chance to do that. We're always pushed for time in webinars like this.
Yes, yes.
So thank you everyone for attending, and I hope you found it informative.
Yeah, well, thank you very much for the invitation.
Yeah, no problem. We really appreciate your time.